Hello and welcome to nursing webinar session. Myself Shanti. We are going to discuss about management of meningitis. For this, I welcome Dr. Komal Kumar Garu, who is our senior consultant, neurologist and Head-Cerebrovascular Unit from Yashoda Hospitals, Secunderabad. I welcome you, sir. We are honored to have you with us today as expert panelist. And I also like to welcome Miss Aishwarya as our speaker from Malakpet Unit, Yashoda Hospital.
Thank you, ma'am.
I welcome you, Aishwarya. Yes. And you can share the slide as we are going to discuss about the meningitis, its early recognition, and a whole lot of management aspects. You can share the slide. Yes, sir. As we are, carrying forward towards the topic, as we would like to have your insight on what is the current situation regarding meningitis, sir, from your insight.
See, meningitis actually is one of the very common infections of the brain.
Yes, sir.
And nowadays in tertiary care center, we are not seeing many patients. But if you go to the primary health centers or these government medical centers, you see many cases of meningitis. And then meningitis can occur at any age, starting from the newborns to the very elderly. And the etiology, then the organisms, they vary from across particular ages. Like suppose in very neonates, the bacterial infections could be because of E. coli. Usually in younger patients, it is pneumococcus. See, that depends upon the age of the individual, then underlying immunosuppression or immunocompetent state. And then sometimes we see this infection in patients who are on chemotherapy drugs,
Yes.
patients with cancer who are otherwise immunosuppressed. And these patients, some of these patients can harbor very rare infectious organisms causing meningitis. And some of these patients can have fungal meningitis, of which Cryptococcus is the most common form of fungal meningitis. In tertiary care center, we are not seeing many, but it is still very, very prevalent in primary health centers and in government teaching hospitals. And it is one of the very fatal illness if not diagnosed early and treated early. And the patients, so even if they are survive, some of them can have severe, left with severe sequelae. So that is the reason recognition of meningitis in early stages. And institution of the treatment is very, very, very important in first few hours. So that is what we call the golden period. So
Yes.
when the patient comes with meningitis, when you are suspecting meningitis, we should be very, very fast. This is like something like, and it's one of the neurological emergencies of the brain. See, we consider stroke as an emergency in neurology. We take myocardial infarction as an emergency. Similarly, on the same ground, you should take meningitis and then act with the similar levels. You should be very, very fast in dealing with the patients of meningitis.
Yes, sir. So Aishwarya, rest of the session you can take forward and we'll discuss further. Over to you.
Good afternoon, everyone. Myself, Aishwarya. Let's discuss regarding meningitis. Meningitis is an acute or chronic inflammation of the protective membranes called meninges, which covering the brain and spinal cord. We can see in this figure, it's a three-layered membrane, which is called dura mater, arachnoid mater, and pia mater. As I said, that meningococcal disease is a potentially fatal and is a serious medical emergency if it is not treated properly. Let's move on to the pathophysiology. The causative organisms like bacteria, virus, fungus, which enters the bloodstream and it crosses the blood-brain barrier. Then it multiply in the cerebrospinal fluid and it causes release of cell fragments and it causes inflammation of the subarachnoid and pia mater. Then the CSF circulate through the subarachnoid space with inflammatory materials.
Sir, so again, we would like to understand here what triggers, inflammation of the meninges in short, sir.
See, this is one route of transmission. Most of these meningitis infections, they are hematogenous, means they enter the brain through bloodstream.
Yes.
So this is most important. Another thing is not only from the hematogenous spread, these organisms can spread through contiguous structures. Suppose if somebody comes with an head injury, so they have an injury to these facial bones, that is cribriform plate of ethmoid. And then through the nose, these bacteria can enter to the brain directly rather than entering through the blood.
Yes.
And some of these patients can have this injury to the temporal bone of the skull. So the mastoids. So from the inner ear, again, the bacteria can enter into the brain. So not only hematogenous spread, these organisms, especially these bacterial organisms, can spread through the contiguous structures also. So this is what we call parameningeal source of infection. So that is again very, very important to look for CS of rhinorrhea or CS of otorrhea in patients who come with head injuries, like whether there is a leaky CS, whether the CSF is leaking from the nose, or whether the CSF is leaking from the ear. As a nurse, we should be very, very, very observant, because these head injury patients, suddenly they develop fever, suddenly they lapse into deep coma. So one of the things which you should suspect in these patients is whether the patient has got any meningitis because of the fracture and then contamination or the percolation of the organisms from the nasal cavity to the brain directly, or from the inner ear to the brain directly. And one of the most common thing is hematogenous spread, but we should not forget about other routes. Sometimes we see some of these nerves, they can spread through the nervous structures also, neurons also. See, you have varicella zoster, that is what we call chicken pox.
Yes.
So once you get chicken pox, what happens is these viruses, they can lay dormant in the ganglia. Ganglia is collection of the neurons, that is neuronal bodies.
Yes.
So from there, after some time, see, sometimes they can lie dormant for many years also, or sometimes during acute phase also. From there, through the nerves, through the nerve sheath, these organisms can enter the brain. So these are the three modes. So one is most commonly is hematogenous. Second is through the contiguous structures, like when you have fracture of the nose, that is cribriform ethmoid, or we have fracture of the temporal bone from the ear, it can enter into the brain, or from the neurons itself, they can have neuronal spread. So these are the three modes.
So I would like to repeat. The first is hematogenous. Second is your the structure, and the third is your neuronal sources.
Yes.
Yes. Glad to hear about this, since we only know a few little things. Yes. Yes, Aishwarya.
Let's look the types and causes of meningitis. As Shah told, it's classified according to the type of bacteria, virus, and fungus. If it is caused by virus, it is called viral meningitis. If it is caused by bacteria, it is called bacterial meningitis. If it is fungal, then it is called as fungal meningitis. In viral meningitis, like Neisseria and Streptococcus pneumoniae. In bacterial, like enterovirus and herpes simplex. In fungal, it is like Cryptococcus.
1 minute. I'll just interrupt. Here, actually, you have just flipped bacteria are Neisseria and Streptococcus pneumoniae, virus are enterovirus and herpes simplex. I think some typo.
Okay, there is a correction. Yes,
correction here.
It is just
so bacteria, this is the Neisseria meningitis, that is meningococcal meningitis, what we call.
Okay.
So Streptococcus pneumoniae, that is a pneumococcal meningitis. So they are bacteria.
Oh.
See, enterovirus is virus, herpes simplex virus. Okay. So these are the viral, means one of the common viruses causing meningitis. See, most of them, there are so many viruses which can cause meningitis. If you see, we send a test called Filmare panel, say, where we check for a lot of viruses.
Yes.
Sometimes adenovirus can cause meningitis. Even COVID also is neurotropic. COVID also can enter into the nervous system, COVID virus. Recently, there are reports that even chikungunya virus, you might be seeing many patients coming with joint pains after fever. Even chikungunya virus also can enter into the brain and cause meningitis. And another thing is dengue fever. See, we are seeing many patients have dengue epidemic now. Sometimes even the dengue also, the dengue virus also can cause meningoencephalitis. That is what we call dengue encephalitis, and somewhat of meningitis also. So this is viruses and then bacteria. Again, if you see the age group in very newborn, means very infants and newborns, the most common bacteria is E. coli. So Escherichia coli.
Yes.
In adult patients, it is Streptococcus pneumoniae, or what we call as pneumococcus. That is the most common type of bacteria causing meningitis. And Neisseria meningitis is a meningococcal meningitis. Coming to the bacteria, the most common are enterovirus, then herpes simplex, and fungal we know cryptococcal meningitis.
And histoplasmosis.
Fungal meningitis.
Okay, so sir, which one is very common and serious?
And one more thing I want to add is, if you see meningitis, the most common organ for bacterial meningitis is Streptococcus pneumoniae. That is what we call pneumococcal meningitis.
Yes.
So this is a Streptococcus pneumoniae, is a gram positive or gram negative? This is a gram positive organism. Whereas E. coli is gram negative. E. coli is in neonates.
Yes.
And if you see very elderly people, like people who are more than 60, 65, there is a bacteria called Listeria.
Listeria, yes.
Listeria is one of the common cause of meningitis. So in elderly people, so you should always consider Listeria as a possibility of meningitis in elderly people. And these patients, these elderly patients, the meningitis can be very, very severe. They can present with brainstem involvement. So they can deteriorate very rapidly within 1 or 2 days. So that is so classical of Listeria. And then your treatment of Listeria is, which antibiotic you prefer in Listeria? Anybody? Is ampicillin.
Yeah.
Ampicillin is the drug of choice in Listeria. Whereas if you take Streptococcus pneumonia, the drug of choice is cephalosporins.
Cephalosporin, yes.
That is ceftriaxone.
Yes.
So the meningitis dose is 2 grams IV 12th hour.
Yes.
Let's look at route of transmission. Infections can be transmitted from person to person through direct contact and respiratory droplet through sneezing, coughing, and more prone to get infection to immunocompromised patients, example, cancer patients.
So, sir, are these the route of transmission? Because we like
actually, meningitis getting transmitted from person to person is rare.
Rare. Yeah,
is person to person is rare. Suppose you don't get Streptococcus pneumonia, and then the only meningitis or the meningitis which can be, so you take dengue, that can transmit from the infection, means from the mosquito, whereas COVID can transmit from person to person, that they are different.
Yes.
So they are the latest causes. But if you see the classical causes of meningitis spreading from person to person through direct contact is extremely rare, except in cases of Neisseria meningitis. Neisseria meningitis, that is, if you are dealing with a case of Neisseria, that is meningococcal meningitis, you have to be very, very careful, because these patients of meningococcal meningitis, they can transmit infection to the healthcare provider. So you have to be very, very careful. You have to wear your mask, and then the droplets you have to take care. Okay.
So contact precaution is mandatory.
Yes.
Early recognition of symptoms is very important in meningitis. They include patient may experience, while receiving the patient may experience severe throbbing headache, continuous high-grade fever, more than 102 degree Fahrenheit to 104 degree Fahrenheit. Patient may experience nausea, vomiting, neck stiffness, drowsiness, photophobia, irritability, and altered mental status like irrelevant talk. In extreme cases, patient may experience seizure-like activities also.
So what are the early signs, sir, which would require sometimes, which may worsen if the patient is just at home?
You have to keep in mind the 3 most common presenting symptoms of meningitis. If somebody comes to you, go back to that slide.
Go back.
Okay.
Yeah, good. If somebody comes to you with fever, headache, nausea, or vomiting,
yes, sir.
Most important thing, see, even if somebody has high-grade fever, even without meningitis also, they can have headache.
Yes.
Because why? What is the reason? Because high fevers can cause cerebral vasodilatation. The vessels in the brain can dilate. They expand because of the fever. So whenever the vessels dilate in brain, you get headache. So fever and headache, sometimes high fevers also, headache can be there. But if the patient has vomiting, nausea, and then drowsiness or irritable, and if you should always, any patient with fever and headache, you should always look for signs of meningitis, whether the patient has any neck stiffness, whether Kernick sign is positive. So if the patient has neck stiffness with fever, headache, he may or may not have vomiting, you should always rule out or suspect meningitis as the cause. And then photophobia, irritability, mental. See, most of the times what happens is patient will not read textbook and come. Patient will not come with all these features which you have not mentioned. Yes. Sometimes some fever may not be there. Yes. Suppose if you take an immunocompromised patient, say fever is what? Fever is a sign of inflammation. So suppose if the patient's immunity is less, suppose in patient with HIV, patients with cancer, patients who are on chemotherapeutic drugs, patients whose immunity is reduced, they may not mount adequate inflammation. So that is the reason patient may not have fever, but they can have headache. And if you do a lumbar puncture, they can show, the CSF can show features of meningeal infection. So these are not classical. Suppose if somebody has these classical features, okay, meningitis is sure possibility. But absence of fever or absence of headache may not rule out meningitis. So anybody who comes with fever, headache, vomiting, or anything, any symptoms which you have mentioned here, you should always look for signs of neck stiffness, Kernig sign, and all that.
And sometimes,
early recognition of these symptoms are very, very, very important.
Very important. And sir, sometimes these are the mimic symptoms of dengue as well, I think. Yes.
Yes.
As sir told, like meningitis can affect almost all groups: infants, preschoolers, children, younger adults. And in middle age and older adults, the most common cause of bacterial meningitis is Staphylococcus aureus and Staphylococcus pneumoniae.
Streptococcus pneumonia.
Streptococcus pneumoniae. Let's look into bacterial versus viral meningitis. Bacterial meningitis is caused by bacteria. It is one of the dangerous type of meningitis and can be life-threatening if it is not treated. Viral meningitis is most common seen among children and milder than bacterial meningitis.
So, sir, are children and pregnant mothers are more prone for this infection, or like who are immunocompromised?
As we discussed earlier, again, children, again, immunity. Children have less immunity, or children are neonates or young infants. They have less immunity compared to adults. Okay, so again, that is the reason they are prone for infections.
Yes.
And these respiratory infections are very, very common in children, these viral infections.
Yes.
So these viruses, they enter into the bloodstream and can enter the brain and then cause meningitis. And pregnancy is an immunocompromised state. So pregnancy as such is an immunocompromised. The pregnant women, their immunity will be very, very low compared to the non-pregnant population. So these pregnant women are again more prone for infections of the brain or infections anywhere in the body. So that is the reason they have to be very, very careful.
Yes.
And go back.
7th or to the age,
yes.
to age group?
See, if you take bacterial meningitis and viral meningitis in most of the cases is self-limiting. See, patients will come with fever, headache, vomiting, or irritability, nausea, and photophobia. And if you have neck stiffness, if you have lumbar puncture, again, this proteins will be elevated, cells will be elevated, and you have predominantly lymphocytes. And sugars will be normal. And most of the times, viral meningitis is self-limiting. So usually it will last for 5 to 7 days and then it goes away. So even if what the patient needs is symptomatic treatment. Suppose if we diagnose early, we put these patients on antiviral medication called, what is that medicine? Acyclovir. Acyclovir. Okay. And rarely viral meningitis can be fulminant also. They can be life-threatening also, because sometimes these patients develop what is called viral meningoencephalitis. They can have infection of the underlying brain parenchyma. See, meningitis is inflammation, infection of the coverings of the brain.
Yes.
Encephalon is the brain parenchyma itself. Okay. So since they are, brain and then the meninges, they are not watertight compartments. If somebody has meningitis, there will be some amount of inflammation or infection of the underlying brain parenchyma also, and vice versa. If somebody has infection of the brain parenchyma, there will be some amount of inflammation of the covering meninges also. So that is the reason we call as meningoencephalitis. Suppose the patient develops encephalitis, patient is in viral meningoencephalitis, patients can have what we call status epilepticus. Okay, they can have continuous seizures. They may require ventilatory support. They might require multiple anti-epileptic medications. Okay, and then sometimes this epilepsy can become refractory, and patients might succumb to the illness too. And bacterial meningitis, again, compared to the viral and bacterial meningitis is more severe. It can be more life-threatening compared to the viral meningitis.
Well, yes.
So if you do a lumbar puncture in these patients, what do you observe? You see predominantly neutrophils. Okay, so neutrophils, and then low sugars and elevated proteins. And then low sugar means, how do you say it is low sugar? How do you say it is low sugar? So with what you compare? With blood sugar, isn't it?
Yes.
You compare with blood sugar and then see CSF sugar. So CSF sugar should normally be around 2/3 of the blood sugar. Suppose if the blood sugar is 100 milligram per deciliter, CSF sugar should be approximately 2/3, 66. Suppose if it is lower than 2/3 of the blood sugar, that means it is CSF sugar is low. And
Low.
most important thing when you are doing a CSF examination and when you are looking for corresponding blood sugar. So you always compare CSF sugar with the blood sugar, isn't it?
Blood sugar.
So when do you draw the blood?
Before lumbar puncture and after lumbar puncture.
No. When do you draw the blood to compare CSF sugar? Most of the times what people do is when you're doing lumbar puncture, simultaneously you do a RBS or blood sugar, isn't it? And then say blood sugar is this much and then CSF sugar is this much. So CSF sugar is low. But that should not be followed. That is not correct. You should take blood sugar at least 4 hours before doing a lumbar puncture.
Okay.
So why it is? What is the reason? Because for the blood sugar levels to parallel with CSF sugar, it would take 4 hours. So many people actually they don't follow it, and then many people are not aware of it.
Aware of this, yes, sir, exactly.
Okay, many people are not aware of it. Suppose when you are planning for a CSF, suppose the consultant comes and says, "Sister, I want a CSF to be done at 10 o'clock in the morning."
Yes.
You should draw blood at 6 o'clock, and then take the sugar. Suppose the patient is in the ICU, and then a lumbar puncture is done, an unplanned lumbar puncture, because emergency lumbar is done at 10 o'clock.
Yes.
So you don't go by the sugar done at 10 o'clock, blood sugar. Anyway, you will be doing a morning blood sugars, isn't it, in the ICUs?
Yes.
So go back to the chart. Go
And
back
we
to
can
the
compare.
what was the level of blood sugar taken around 4 hours before the lumbar puncture. Take that as a corresponding blood sugar. Okay,
Very valid point.
as these
Exactly.
patients are, they don't come because, and then most of the times these CSF are done on an emergency basis, isn't it?
Yes.
You don't plan it 4 hours because we need an immediate results to start treatment. So go back and see what was his previous blood sugar, done around 3 hours, 4 hours before. You can take that blood sugar as into consideration, not the blood sugar which you do at the time of lumbar puncture.
Yes.
So actually that can be an erroneous thing. So it's a fallacy. So many other times what happens is you take the corresponding blood sugar. It should not be followed. So you should take, if you are planning a lumbar puncture, you should take the blood sugar at least 4 hours before planning the lumbar puncture.
So we urge all the nursing staff, just now sir has, discussed about the very valid point to corresponding blood sugar before prior LP is very important.
And as nurses, actually you are the primary healthcare providers, isn't it?
Yes.
You are the first point of contact. So you are the ones who take care of the patient 24 hours.
Yes.
Okay, you should learn this point and convey this to your consultants.
Yes.
Convey to your intensive care specialists, convey to your neurologist, convey to your internal medicine specialists. Okay, most of them, they won't agree.
Yes.
They won't say it is not correct, but this is correct. Okay.
Yes, sir.
These are the major clinical symptoms as told to us. They are neck stiffness, Kernig sign, and Brudzinski sign. In Kernig sign, when the patient is lying with the thigh flexed on the abdomen as shown in the figure, the thigh can't be completely extended. In Brudzinski sign, when the patient neck is flexed, flexion of the knees and hips is involuntarily seen in patients.
So,
Again,
sir, why do, as you said, this is the very early warning signs, and why do neck rigidity, pain, and resistance is being
so
felt?
this is because of the inflammation of the meninges.
Okay.
When you are doing these Kernigs and Brudzinskis, what happens is the meninges get stretched. Meninges get stretched.
Yes.
When there is an inflammation, say when the meninges become inflamed, what happens? There will be pain.
Pain. Yes. Sir.
Okay.
Yeah.
So that's the reason the patient winces. And then the protective flexion, when you are doing a neck flexion, the patient flexes his both lower limbs.
Yes. Sir.
That is to reduce the stretching of the meninges, inflamed
Yes.
meninges.
Yes.
So when do you why do you have joint pains when you extend your elbow, when there is an elbow inflammation? That is because the stretching of the joint, because it's inflamed joint, it causes pain. Similarly, when you are stretching the inflamed meninges, it causes pain. So to reduce that stretching, patient will flex his both lower limbs.
Okay, sir.
In Brudzinski's. So these are signs of meningeal inflammation.
Yes.
One more important thing, most important thing is if somebody comes with severe headache and vomiting, fever may or may not be there. And if you do a bedside examination, he has severe neck stiffness, Kernig sign is there, Brudzinski sign is there. So another thing apart from meningitis, what do you suspect in neurosurgical ICUs or neurology ICUs? Subarachnoid hemorrhage. what we call SAH. Okay, SAH also can represent severe headache and signs of meningism. What we call meningism. So they can have neck stiffness. So subarachnoid meningitis also is one of the DDs, differential diagnosis, in patients with acute onset of headache and meningeal signs.
For an initial assessment of a meningitis patient, patient complaints are to be addressed. Thorough physical examination like clinical symptoms should be evaluated. As per assist in lumbar puncture for CSF analysis. Before LP should evaluate papillary edema. CSF will be sent for analysis of protein, sugar, cell count, culture, gram strain, and preliminary meningitis panel also. If patient sensorium and GCS is not good, it is indicated for CT brain also. Blood investigation like AMC profile should be done. It includes complete blood profile, liver function test, renal function test, electrolytes, chest X-ray, and ECG.
1 minute. Okay, very good. Once you have diagnosed clinically that patient has come to you with fever, headache, vomiting, and you did your blood side test, you saw patient has neck stiffness, his Kernig sign is positive, his Brudzinski sign is positive, his running temperature, okay, he is irritable, he is not able to see your light in the ICUs, that means he has photophobia. So you are planning for establishing the diagnosis.
Yes.
So as to establish diagnosis, you are planning for a lumbar puncture, as you have said here.
Yes.
But before doing a lumbar puncture, before arranging for a lumbar puncture, you should make sure that you get a CT scan, imaging of the brain done. Okay, this is most important. Never do a lumbar puncture without getting a CT scan of the brain. Sometimes these patients can have severe cerebral edema. And then if you do a lumbar puncture without a CT scan, sometimes they can have herniation of the brain.
Herniation of the brain.
Okay, this is very important. Sometimes these patients can have underlying structural lesions.
Yes.
Okay, so it is most important. See, in olden days, okay, before the CT scan era, before the CT scan was not available, based on the clinical findings, only people used to do lumbar puncture and then diagnose or rule out meningitis.
Yes, sir.
Now we have CT scan everywhere. When you are planning a lumbar puncture, always make sure that you do a CT scan first. And then rule out a severe cerebral edema, rule out a structural lesion, rule out a major bleeding in the brain.
Yes, sir.
Okay, before doing a lumbar puncture. And then go back.
Go back to the previous slide.
And then some of these meningitis patients, they can be what we call raised ICP because of the infection or inflammation of the meninges, infection in the brain. They can have raised ICP, raised intracranial pressure.
Yes.
So CT scan, sometimes what we do is to measure the intracranial pressure. In the bedside also, we look in the optic nerve sheath with an ultrasound. Okay. So suppose the optic nerve sheath diameter is increased, that's an indirect evidence of raised ICP. So you have to alert your physician. Okay, you have to alert your critical care specialist. So you can suggest him, doctor, why can't we do an ONSD and see whether the ICP is raised. Okay, before getting a lumbar puncture. And then if there is elevated ICP, you have to give osmotic agents to reduce the intracranial pressure before doing a lumbar puncture.
Yes.
Okay, otherwise, in a patient with raised ICP, if you don't rule out a raised ICP and you do a lumbar puncture, if the patient has elevated ICP, patients can have herniation. Patient can sometimes die also after
lumbar
puncture because of the herniation of the brain stem. Okay.
Yes.
So let's look.
So always try to get a imaging
first
before doing a lumbar puncture. This is most important. And then
yes, sir.
go back. And then you are doing a CSF, isn't it?
Yes, sir.
When you are collecting a CSF, you collect in a plain glass bottle or test tube, isn't it?
Yes, sir.
So as a nurse, so you should always see CSF also will give a lot of clues to us.
Yes.
The appearance of CSF.
Yes.
Okay. So in pyogenic meningitis, CSF can be hazy. See, CSF is just like, looks like a water, isn't it?
Yes.
Normal CSF. In pyogenic meningitis, that is bacterial meningitis. Sometimes it will appear as hazy. Sometimes you can see frank pus.
Yes.
Okay. CSF looks like frank pus. That means it is for case of severe bacterial meningitis. Suppose if you see blood if you see blood along with CSF, okay, sometimes there are some infections where in meningitis where they can be hemorrhagic. Like you see in varicella zoster virus meningitis, there can be hemorrhage in the CSF. Okay. Sometimes
Okay.
listeria, there can be bleeding.
Yes.
And or if you see a frank blood in a lumbar puncture in a so-called case of meningitis, what do you suspect? Subarachnoid hemorrhage.
Hemorrhage. Yes.
Subarachnoid hemorrhage also can present like meningism. They can have headache, vomiting, fever may or may not be there. So appearance of CSF also is very, very important. In olden days, see, you send the CSF for cell count, cell type, okay, protein, sugar. And apart from sending that, you always try to keep a CSF sample at the bedside.
Yes.
And olden days, what we see is in case of subacute meningitis or chronic meningitis. So apart from these common bacterial infections and then these viral infections, another common meningitis which we see in our country is tuberculosis meningitis. Isn't it?
Yes. Yes.
So that we have not discussed yet. This tuberculosis, again, a common cause. It presents usually as a subacute meningitis. Means patients usually have fever, headache, vomiting of more than a week duration or 2 weeks.
Yes.
Okay, that is called subacute. Or sometimes they can have headache and vomiting for more than 2 to 3 to 4 weeks. But we have seen patients with tuberculosis meningitis presenting as acute. So they can have just fever, headache of 3-4 days duration only. And then do a CSF, your Zine expert can be positive. Sometimes you can see rarely AFB also. And that is the reason in our country, say, apart from sending the CSF for sample means to the lab for investigations, always keep a CSF at the bedside and look after few hours or 24 hours to look for what is called cobweb. Cobweb. Okay. So if the patient, the CSF is showing cobweb, that is very classical of tuberculosis.
Yes.
Okay, tuberculosis meningitis. That is what we call cobweb.
Yes.
Let's look into the nursing care coordination and handover process. It is very important for nurses. While receive the patient, ensure IV access is placed for drug therapy. Connect the patient to monitor, check for vital signs, temperature, pulse, blood pressure, respiratory rate, oxygen saturation, and document it. If anything is abnormal, escalate to doctors immediately. Check GCS score of the patient, pupillary response also. Place Foley's, monitor intake and output of the patient. Diet should be provided for the patient as per doctor's order and patient status. If taking orally, oral diet or otherwise rise to feed. Change the position to avoid pressure ulcer for a bedbound patient. And if patient is restless, restrain the patient with informed consent to the attenders. Hygienic care to be done to the patient because they are in a bedbound status, especially sponging, oral care, Foley's care. Monitor patients for seizure activity, immediately inform doctors and immediately start anti-epileptic therapy also. Ensure side rails have to prevent the fall of the patient.
So, sir, you mentioned cobweb, which is COBWEB.
Yeah.
Yes. And sir, the nursing care, which is mentioned in this slide, you would like to add from your point of view any other factors which we have missed out?
Yes. See, once you ensure IV access, the first thing you should do as a treating nurse in a patient with acute meningitis is to give antibiotic.
Yes.
So that is the most important thing.
Come to medication, Aishwarya.
Yeah.
Yes.
So this is the most important thing. If you are suspecting a case of meningitis and then you have drawn the CSF and then don't wait for the results to come. See, suppose the CSF is hazy. If the history of the patient is very short, sometimes these patients come with just fever, headache and vomiting of 2 days duration. And then you have frank neck stiffness and then your CSF is hazy. You know that you are treating a case of bacterial meningitis. Don't wait for the lab reports to return. Just give him a dose of ceftriaxone, meningitic dose. So as a nurse, that is the most important thing to do. Because the earlier you give antibiotic, the better will be the outcome. So the delay of giving antibiotics by few hours also can adversely affect the outcome of these patients. And another important thing, if you are treating a case of bacterial meningitis, is Dexona. See, when you are along with the first dose of antibiotic, you give dexamethasone.
Yes.
And then you do not give it for more than 1 or 2 doses only. Because if you give more doses, more steroids, they can cause, again, they are met with deleterious side effects. we give it a single dose or 2 doses of Dexona along with the first dose of antibiotic only. And then we don't add steroids after starting antibiotics, especially in bacterial meningitis. Rarely some of these patients can have another like problems like vasculitis and all that. So that is a case where there are situations in which we add corticosteroids. But in case of viral meningitis, we give steroids to reduce inflammation and along with acyclovir.
Yes.
So the emphasis is when you are suspecting bacterial meningitis, when you have drawn the CSF, don't wait for the lab results to come. Give first dose of antibiotic ASAP, that is immediately. So ceftriaxone in meningitic doses, that is 2 grams in adults, it is not 1 gram. Ceftriaxone in adult dosage is meningitic doses 2 grams twice daily. In children, it is 100 mg per kg body weight. Okay.
Yes.
And then you can add vancomycin along with ceftriaxone if you are suspecting a gram-positive meningitis.
Yes. So we have almost come to the end of the discussion, and you can share the slide, Aishwarya, and we would like to hear the preventive tips from your end, sir, and the role of meningococcal vaccine.
Yes,
Who to
now,
take, because-
yeah. So patients actually nowadays, these vaccines, especially we have pneumococcal vaccine also. Pneumococcal vaccine, meningococcal vaccines, and then elderly people who are immunosuppressed, immunocompromised, people who are on chemotherapy, people who have malignancies, and then people who have uncontrolled diabetes. So these are the patients, people who have to take these vaccines. They are definitely helpful. They'll reduce the incidence of meningitis. If somebody gets meningitis, so the severity will be less compared to the people who have not been vaccinated.
Yes. So
And,
yes,
practice
I
good
think,
hygiene,
yeah, that was a very great discussion, sir. And I'd like to thank you, and thanks for your valuable time, and thank you, Aishwarya. I think viewers, I'd like to request whatever the instruction has been carried out or spoken just now in this webinar should be followed, and thanks to all viewers. Join us every Thursday at 3 p.m. for next interesting topic, and until then, take care. Thank you, sir. Thank you, Aishwarya.
Any questions from the audience?
Sir, they'll be posting in FB, and if at all they post, I'll
Okay.
forward to you, sir.
Right.
Whatever, yes.
Perfect. Thank you.
Thank you, sir.
Thank you.
Thank you
Pleasure.
so much.